morning everyone. Today's topic for the discussion on continuous cardiac education is Alcapa, that is anomalous origin of the left coronary artery from the pulmonary artery. Now coming to the normal anatomy of the heart. The normal anatomy of the heart is supplied by the two coronary system, that is right coronary system and the left coronary system, which are both originate from the aorta. But in the Alcapa, that is the anomalous origin of the left coronary artery from the pulmonary artery, the right coronary system is originated by the aorta, and it is supplied the oxygenated blood to the right side of the heart. But the left coronary system, that is the left main coronary artery, which is giving rise to the branch of the left anterior descending in the left circumflex, is originated from the pulmonary artery, which can give the deoxygenated blood to the left side of the heart. So in Alcapa, the blood supply to the heart is different. The right side of the heart is getting oxygenated blood supply, while the left side of the heart is getting the deoxygenated blood supply. Now coming to the definition of the Alcapa, the whole of the left main or only the left anterior descending or circumflex branch connect anomalously to the proximal main pulmonary artery or very rarely to the proximal right pulmonary artery is called as the Alcapa. Now coming to the history, the Brooks first described the Alcapa disease in 1886. Then after, the clinical syndrome is first described in 1933 by the Bland, White and Garland, which is also, so the Alcapa is also called as the Bland, White and Garland syndrome. The first successful operation was done in 1959 by the Sebastian. He was performed the surgery that he clamped the left main coronary artery from the pulmonary artery. So by that way, it decreased the coronary still phenomena. Now, followed by the various surgical techniques is developed. In 1966, the Cooley's used the bypass grafting surgery for the Alcapa repair. Followed by the major changes occurred in 1974 by the Natchez, which can operate the Alcapa patient and do the coronary transposition. That is, it remove the left main coronary artery button from the pulmonary artery, and it's again re-anastomosis on the aortic side. And the recent advances, that is in 1980, the Takeuchi repair is done, which is the tunnel repair, that is an intra-arterial Buffalo tunnel repair is done. This is mainly operated for if the Alcapa origin, that is the left main coronary artery is origin from the non-facing sinus of the pulmonary artery, that the translocation from the non-facing sinus to the facing left main sinus is difficult for the surgery. So intrapulmonary baffle surgery is used to connect the left main coronary artery to the aorta. Now coming to the external anatomy. In this external anatomy, we can see the right heart is the bright and it is supplied by the oxygenated blood, while the left heart is a very dusky. And you can see that there is a Alcapa origin. That is in the PA, there is a lower part is the left main coronary artery, which is give rise to two parts. That is the left anterior descending part and left subclavian artery. Similarly, in internal anatomy of the right heart, the cut section of the right heart can give rise to the right ventricular outflow tract, followed by the pulmonary artery and the pulmonary valve. In pulmonary artery, you can see that there is an opening in the one of the pulmonary cusps, that is the cusp number 1, sinus 1, which that can give rise to the left main coronary artery. It is called as the Alcapa. Now coming to the types of Alcapa. The basically types of Alcapa is mainly two types, that is the infant type and the adult type. So in the neonatal period of the life, the pulmonary pressure is equal to the aortic pressure. So the antegrade flow in the left coronary artery, that is the coronary artery arises from the pulmonary artery, to the left coronary artery. So there is no symptoms is developed. During the infantile period, after the 2 to 3 weeks of the life, the PA pressure is gradually fall. So the pressure of the PA is decreased to the pressure of the aorta. Now coming to the pathophysiology, the retrograde flow from the left coronary artery is supplied by the right coronary artery. So the aortic pressure is high. From the aorta, the blood supply is going to the right coronary artery, and from right coronary artery, the supply is going to the left coronary artery, and from left coronary artery, it is going to the pulmonary artery. So it is called the pulmonary coronary steal phenomena. Now coming to now coming to the further pathophysiological changes in infant life, there is no collateral development between the right coronary artery and the left coronary artery. So the right coronary artery supply the right heart, it's getting the oxygenated blood supply, while the left coronary artery, left side of the heart is getting the deoxygenated blood supply. So there is a chronic myocardial ischemia is going to happen, which can cause the ischemic cardiomyopathy due to chronic infarction, and the 90% of the death is occur in the first year of the life due to the acute cardiac failure. Now coming to the adult type of the Alcapa. In adult type of Alcapa, the similar pathophysiologies occur like in infant type, but the main advantage, main changes in the adult type of Alcapa is there is abundance collateral development in between the right coronary artery and the left coronary artery. So the left side of the heart can get the oxygenated blood supply to the multiple collaterals developed between the right coronary artery and the left coronary artery, and the size of the right coronary artery due to the development of the multiple collaterals is very large. So in this patient, the patient may present with you in OPD at the age of around 50 to 20 years in the second decade of life, and in coronary angiography or in the coronary angiography or CT angiography, you can see the very large size of the right coronary artery. This type, similar like in the infant type of Alcapa, the chronic deoxygenated blood supply to the left side of the heart can cause the chronic myocardial ischemia and dysarrhythmias, and the sudden death may be precipitated by the in adult type of Alcapa. The second changes is that due to the chronic inflammatory reaction, the chronic ischemic changes, the diastolic dysfunction is occurred. So the diastolic dysfunction is occurred that can cause the subendocardial ischemia and subendocardial fibrosis. So filling pressure is also hampered in the chronic adult type of the Alcapa. Now coming to the various difference between the infant versus the adult type of Alcapa. The clinical manifestation in the infant type of Alcapa is the patient is symptomatic in early age of life with the patient presented with the heart failure symptoms. In adult type of patient, there may be asymptomatic, the subclinical ischemia is present, and patient may present with sudden death. Now ECG finding, there is a ischemic changes in the ECG finding. In adult type, due to chronic long-standing subendocardial fibrosis and subendocardial thickening, the left ventricular hypertrophy is occurred and the ischemic changes is also present. The infant type of Alcapa, the right coronary artery is mildly dilated, while in the adult type it is markedly dilated, a very huge right coronary artery you can see in the CT aortogram or the angiography. The collateral is insufficient developed in the infant type of Alcapa, and there is a abundance collateral developed in the adult type of Alcapa. The wall motion abnormalities, there is a mainly anterior lateral wall hypokinesia, while in adult type there is a none or the global hypokinesia. Left ventricle in infant type, due to the ischemic cardiomyopathy, it is a dilated left ventricle, while in adult type due to there is a chronic subendocardial ischemia and subendocardial fibrosis, the LV size may be normal or mildly dilated, but usually it is a hypertrophy. The outcome of the infant type of Alcapa is a myocardial infarction and death in the first year of life, and in adult type of Alcapa, if it is operated early, that is outcome is good, but may be present with the sudden death due to the ischemic ventricular dysarrhythmias. Now coming to the morphology for the Alcapa is mainly divided into the connection to the connection of the left coronary artery segment to the pulmonary artery. The second is the left ventricular morphology, and third is the mitral valve morphology. Now coming to the in normal adult, the aortic valve has three curves, that is curves 1, 2 and non-facing curves. The right coronary curves giving rise to the origin of the right coronary artery, the left coronary curves giving rise to the left main coronary artery, and the non-facing that is curves 3 is not giving any rise to the coronary artery. The main two curves is important. Now coming to the Alcapa segment. The Alcapa segment, the right coronary artery is arising from the sinus 1, but the non-coronary, the left coronary artery is arising from the pulmonary artery. So by this mean, if the left coronary artery is arising from the sinus 1 of the pulmonary artery, then the translocation of the in intra-op surgery, the translocation of the left coronary artery segment to the segment to cusp 2 of the aortic valve is easy. So in that patient, we can do the directly to the translocation of the translocation surgery can done. But if the left coronary artery is arising from the non-facing sinuses, the translocation is very difficult to occur. So in that cases, we can use the intra-pulmonary artery baffle surgery, that is Takeuchi repairs. Now coming to the morphology of the left ventricle. The left ventricle, in like we discussed earlier, in adult type of Alcapa, the left ventricle is hypertrophy, or in the infant type of Alcapa, the LV is dilated due to the ischemic cardiomyopathy. There is also due to the chronic myocardial ischemia, there is a diffuse fibrosis and the diffuse fibrosis present in the subendocardial layer, and there is a secondary subendocardial fibroelastosis also present, which can give to dysarrhythmia in the later stage of life, and patient may present with the sudden cardiac death due to the subendocardial fibroelastosis. Now coming to the morphology of the mitral valve, the mitral valve mainly due to the dilated cardiomyopathy, the annulus is dilated, which can cause the mitral valve incompetence and the mitral regurgitation. Now, factor enabling the survival. The survival is mainly depend on the these main 4 factors. The first factor is the abundance of the interarterial collaterals. If the collateral is good, from the right coronary artery to the left coronary artery blood supply is good, so the retrograde left ventricular perfusion is occur. Now coming to the right coronary dominance, the right coronary dominance is present, the lateral myocardium is supplied by the left coronary artery, so the survival is the good. Now coming to the third part is the minimal steal from the pulmonary artery. In this changes, the left coronary artery, that is originated from the pulmonary artery, the ostial maybe gets stenosis, or there is a restrictive opening into the pulmonary artery, can lead to decreased chances of the coronary steal from the right coronary artery to the left coronary artery and left coronary artery to the pulmonary artery. So the decreased chances of coronary steal can improve the survival of the patient. And last is the development of the systemic blood supply to the left coronary artery. Likewise, in the bronchial artery collaterals also from the bronchial arteries, the collateral vessel is also developed and can give rise to the collateral supply to the left coronary artery and the oxygenated blood supply to the left side of the heart. Now coming to the pathophysiology of the Alcapa. In Alcapa, the main 2 pathophysiology changes is that the first one is the left side of the diagram, that is runoff to the pulmonary artery coronary steal, and second is the collateral dependent flow. Now due to there is a runoff of the pulmonary artery coronary steal, that is from the right coronary artery, the blood supply goes to the left coronary artery. From left coronary artery, due to the decreased pulmonary pressure, the supply is still into the pulmonary artery, which can decrease the anterior coronary flow, which can decrease the chronic left ventricular ischemia. Now chronic left ventricular ischemia can cause the endocardial injury, fibroelastosis, and which can cause the diastolic dysfunction. The left ventricular ischemia can also can cause the papillary muscle infarction and dysfunction, which can give rise to mitral regurgitation. The papillary muscle infarction and dysfunction can cause the free wall rupture or the ventricular rupture, and the patient may present with the infarcted ventricular rupture, and patient may present with the decreased contractility with the low cardiac output state. Now coming to the investigation part of the Alcapa. In ECG, due to the chronic myocardial ischemia, the pathological finding for the myocardial ischemia is the pathological Q wave with the inverted T wave. Likewise, we can see the Q wave and the inverted T wave we can see in the lateral leads of the in the ECG lead. Now coming to the echocardiography. In echocardiography, we can see that there is a pulmonary artery opening, followed by in which there is a left coronary artery opening, and the flow from the left coronary artery is we can see. So sometimes we can also see the steal flow from coronary steal phenomena in this echocardiography also. That is, the flow from left coronary artery is going to the pulmonary artery. In this echocardiography, we can also see the pulmonary valve. Above the pulmonary valve, there is a aortic valve. Above the aortic valve, there is a pulmonary valve, which can give rise to left main coronary artery, and it is divided into 2 parts. That is the left subclavian artery and the left anterior descending artery. Now coming to the CT imaging. CT imaging also the one diagnostic modality for the diagnosis of the Alcapa, in which we can see that there is from aorta the opening of the right coronary artery is seen, and from the pulmonary artery we can see the opening of the left main coronary artery. In angiography, we can assess the size of the right coronary artery and the collateral development for the right coronary artery to the left coronary artery. In left side of the angiography, there is a right aorta giving rise to right coronary artery, and the pulmonary artery is giving rise to the left coronary artery with the multiple collateral vessels in between them. Now coming to the diagnostic finding and significance. What is the diagnostic if we can visualize from the left coronary artery coming from the pulmonary artery, that is the pathological hallmark for the diagnosis of the Alcapa. The second is the retrograde flow from the left coronary artery into the pulmonary artery. It can indicate the still phenomena of the Alcapa. The third is the right coronary artery dilated and the tortuous, that can give significance to the chronic left to right shunt. You must be thought that why it is left to right shunt, not the right to left shunt. But here it is the Alcapa is the mainly extracardiac left to right shunt, because the blood supply from the aorta it goes into the right coronary artery. From right coronary artery it goes into left coronary artery. Left coronary artery, the coronary still phenomena into the pulmonary artery. Likewise in the PDA, the supply between the aorta and the pulmonary artery can give rise to extracardiac left to right shunt. Same, this is the extracardiac of the left to right shunt. Now second is the intercoronary collateral vessels. Intercoronary collateral vessels can give rise give thought about the collateral pathway between the RCA and the LMCA, and if the number of the collateral is good, the patient may present with the symptoms in the second decade of his or her life. Coming to the left ventricular hypertrophy and the dilatation, that it can give rise to that can give idea about the chronic myocardial ischemia. The mitral regurgitation and the prolapse can give an idea about the myxomatous degeneration in the myocardial ischemia. The regional wall muscle abnormality can give idea about the global hypokinesia. Dilated bronchial arteries can give idea about the systemic supply to the left coronary artery. So after the surgery, the endotracheal bleeding is chances of the endotracheal bleeding may be high. So during the induction of the anesthesia, we should do the gentle scopy and the gentle intubation in this type of patient. And the last is the delayed subendocardial enhancement can in CT imaging can give rise to idea about the subendocardial ischemia. Now coming to the goal of the surgery. The goal of the surgery is the establishing the two coronary system with direct aortic implantation. So the translocation of the Alcapa segment, that is the left coronary artery from the pulmonary artery to the aorta, is the operation of the choice nowadays. The situation where direct aortic implantation is not suitable, that is the anomalous orifice is located in the non-facing sinuses as described earlier, or in the lateral position on the left pulmonary sinus, and the patient is older with the well-developed collaterals around the pulmonary sinus. So now technique of the operation. The technique of the operation is mainly two techniques. The first is the construction of the two coronary system by various techniques. Like first is the tunnel operation like a Takeuchi repair. Second is the left coronary artery transfer. Third is the subclavian left coronary artery anastomosis. Fourth is the mobilization with the coronary button. Fifth is the extension of autologous flap of aorta or PA, and the sixth is the CABG. And the in older dialects in Sebastian first performed the Alcapa surgery by the ligation of the left coronary artery to decrease the chances of the still phenomena. So first in first images in left side there is a repair of the Takeuchi repair, in which the Alcapa segment is facing the non-facing sinus of the pulmonary valve. So the translocation is difficult for this type of surgery. So they do the intrapulmonary baffle intra-arterial, that is intrapulmonary baffle development, and it anastomosis with the aortic aorta. And second is the reimplantation, that is a translocation of the Alcapa segment to the aorta. Now coming to the anesthesia goal. The anesthesia goal is mainly, first is the increased diastolic pressure to maintain the coronary perfusion, because in adult type or in the chronic Alcapa patient, the chronic subendocardial ischemia can lead to diastolic dysfunction. So the diastolic dysfunction can cause the increase the left ventricular end diastolic pressure. So if the left ventricular end diastolic pressure is increased and we can decrease the diastolic pressure, the coronary perfusion pressure is hampered. So during the induction of the anesthesia, we should maintain the diastolic pressure throughout the induction and till the patient is went on the pump. Second is the avoid the tachycardia, because the tachycardia can cause the decrease the diastolic filling, which can further decrease the diastolic pressure, and it can increase the chances of the perioperative myocardial infarction or ischemia. Third is the decrease the coronary still, and fourth is the pressure balance between the systemic and the pulmonary circulation. Now, what are the anesthesia concerned during the Alcapa? The first is the degree of myocardial dysfunction is the factor that dominates the condition and prognosis of this patient throughout the perioperative period. So, for the preoperative assessment, we should assess the degree of the myocardial dysfunction and the complication due to myocardial dysfunction, such as the respiratory, renal or hepatic dysfunction, to rule out any other system abnormality. So, we should do the thoroughly echocardiography with laboratory investigation, and to rule out if there is any association with the other system dysfunction is there or not. The most important thing that during the induction, if the diastolic pressure is going to down or diastolic pressure is decreased, the patient may went into the arrhythmia, or patient may went into the arrest, cardiac arrest. So we should prepare to hyperinize and defibrillate the patient is any time during the induction. The induction is mainly slow titration with the small increment of the dose, because this patient is chronic low output stage. So there is sympathetic stimulation is high. So if we can give a higher dose of propofol or higher dose of fentanyl or higher dose of etomidate, the sympathetic supply to the heart is cut off, which can cause the decrease the cardiac output, and patient precipitate with the low cardiac output syndrome. So the induction should be a slow with small increment of the drugs. Now coming to the main factor, that is we should maintain maintenance of the slightly elevated PVR, because in other left to right side, like in ASD, VSD or PDA, we should decrease the PVR by high oxygen saturation, high FiO2 or with the high respiratory rate to maintain the PVR. But in this case, if we give a 100% FiO2 with the high respiratory rate, it can decrease the PVR. So from that, this way, it can cause the coronary still from the right coronary artery to the left and left to pulmonary artery, or increase chances of the myocardial dysfunction during intra-op. So to minimize the coronary still by avoiding the high inspired oxygen concentration and maintaining the normal or moderately high arterial carbon dioxide level. So in this FiO2 around 21 to 50% is allowable, with the PaCO2 around 45 mmHg. Now coming after the induction, the delivery of the cardioplegia is also important, because to arrest the heart, the right side of the heart is supplied by the right coronary artery, which is originated from the aorta, and the left side of the heart is supplied by the left coronary artery, which is originated from the pulmonary artery. So, during the initial phase, like during starting of the surgery, to arrest the heart, we should cannulate both the arterial, that is the aorta, and the pulmonary artery. We can give the cardioplegia through both this route, and followed by after the arresting of the heart, we can remove the pulmonary artery cardioplegia, and then we can remove from the pulmonary button. If the translocation surgery is planned, then remove the button from the pulmonary artery, repair the pulmonary artery, and translocate to the aorta. And after the surgery, the weaning from the CPB is also very challenging, because the patient is in chronic low cardiac output state. Patient may be preoperatively is intubated, or patient is in ECMO support, and patient may present with the circulatory collapse during the preoperative period. So significant risk for the myocardial failure and the circulatory collapse is suspected during the weaning of the CPB. So the criteria for the CPB weaning, we can give the adequate inodilator support, like in milrinol or dobutamine or levosimendan, to enhance the contractility and decrease the afterload for the LV, because the LV is in this patient is chronically low output state, chronically ischemic LV. So for that, we have to decrease the afterload to decrease the LV function. The second is we can improve the coronary perfusion by improve the diastolic pressure by maintaining the afterload. We can add the noradrenaline or vasopressin or adrenaline support to maintain the diastolic pressure of the heart. Thank you.